Good evening, everyone. As people join our webinar this evening from the Congenital Heart Surgeon Society, CRQ Partial Heart Transplant PHT Registry, before I hand over the webinar to Dr. Jam, I will just recommend that people use the chat box or the Q&A pod. Q&A pod is preferable for your questions so that the speakers can better see them. And at this point, I will hand over the webinar to our presenters.
Hey, thank you so much. My name is Hani Najm. I'm the chair of pediatric and adult congenital heart surgery at the Cleveland Clinic, and I also chair the Cleveland Clinic arm of the CRQ Center for Research and Quality of the CHSS. That is also going to be managing the partial heart transplant or the heart valve transplant registry that would be at the Cleveland Clinic. And I'm excited actually to share this webinar also. We have with us Dr. Jake Jaquist, who is the president of the Congenital Heart Surgeon Society, as well as Dr. David Kalfa and Dr. Doug Overby. And I would like to start off with allowing Dr. David Kalfa and Dr. Overby to introduce themselves as leaders of the Partial Heart Transplant Registry. David?
Yes, thank you, Hani. So I'm Dr. Kalfa. I'm the Chief of Pediatric Cardiac Surgery and co-director of the Heart Institute at Nicklaus Children's Hospital, and Professor of Surgery and Pediatrics and Biomedical Engineering at FIU. And I'm excited to present along with Dr. Overby, this webinar on the CHSS CRQ Partial Heart Transplant Registry.
I'm Doug Overby. I'm at Duke University. I'm a congenital heart surgeon there. I've been working over the last 4 years with my partner, Dr. Joe Turek, on kind of getting partial heart started off the ground and then going through our initial series with that, and then working with Dr. Jaquist, Kalfa, and Najm on getting this registry going. So we're excited about what partial heart has brought to the field and how we can push it further forward.
Thank you. Jake, you want to say a couple of words also as a welcome from the president?
I appreciate everybody's time. This webinar is a kickoff of a lot of work that David and Doug and others in conjunction with Cedric Menaho at the CRQ have done. I think the leadership of those gentlemen and people and others is remarkable. This is a paradigm changing therapy. And I think rather than run it as the Wild West, the decision of these leaders to organize this in a way that the data can be examined, used, and inform the proper role of this is remarkable. So I'm grateful to both of them, both for their efforts in leading this, but also in assembling the organizational wherewithal to give us a structure to work in. So I'll shut up and thank all of them and thank all the people who have joined us this evening.
Thank you, Jake, for setting the grounds forward. So I'm going to hear from David, and I'd like to remind people, please participate as you go. Put in some questions through the chat, even through the talk, and we will try and go through them as we finish this talk. So David, please go ahead.
Okay. Thank you very much. So so at the last meeting of the CHSS, right, at the annual meeting, we made a decision that we will move forward with a registry, a prospective and longitudinal registry for partial heart transplantation. So what do we know and what we don't know? We don't know a lot of things. But let's start with the beginning. As Doug mentioned, the team at Duke did the first partial heart transplantation, in 2022. So what the concept of that? I think that all the people who are here are already aware of what it means. But basically, to make it simple, it's the use of a fresh and living homograft. Trying to reduce also the cold ischemic time as much as possible for implantation and the use of immunosuppression. Okay, to summarize the concept. So the key advantage here is that the valvular homograph can grow with the patient, and we'll show what we know about that. There are still some key limitations about donor availability and the limited ex vivo viability and the immunogenicity of this valve. So as I was mentioning, the first one was done at Duke in April 2022, and baby Owen, right? Doug and Joe and Conrad showed basically in a paper in JAMA 2024 that this valve seems to be, growing with, this follow-up of 450 days initially. Then at Columbia, we performed actually the first domino valve transplantation roughly 1 year later. Here, the concept is the fact that we use a valve coming from a patient who receives a heart transplant. So instead of waiting the valve coming from the explanted heart, right, we actually use this valve. So that's the concept of a domino valve. And this is a novel source of living valve, which could potentially double the donor pool of available tissues. In this paper from Jack, we showed and we confirmed, what was shown for baby Owen, which is basically the fact that these valves still seems to grow, right? You can see here the aortic valve diameter and the pulmonary valve diameter, which is growing, and this core of this valve pretty stable. Doug and Duke's group went into a little bit more detail in terms of assessing the length of the leaflet of this transplanted valve, both in the aortic and the pulmonary position in 9 recipients, and showed that this leaflet seems to actually have an increase length in favor of a real growth instead of just a dilation of this aortic root. We showed that there is some valvular immunogenicity, right? Definitely. Basically, many of these patients, if not all, develop some DSA, donor-specific antibodies, and some PRA, panel-reactive antibodies. But we are not sure yet about the actual, implication and the clinical significance of this valvular immunogenicity. So based on these few patients, then we actually led a multicentric study that we presented at the last AATS. The manuscript is almost ready and will be published and will be submitted to the Lancet in the coming weeks. This multicentric study report, all the cases done between April 2022 and April 2025. Okay, these patients come from Duke, Columbia, MUSC, and Boston. 35 patients total for a total of 42 valves. And we just wanted to report actually and to describe, the safety of this procedure and what it means in terms of allograft growth and allograft function. So I will give you a very, very quick overview of what we know so far in this series, just as a bridge, to what we don't know basically. Okay, so the indication for heart valve transplantation, the most frequent indication is actually a combined aortic or truncal and a pulmonary disease. Right, then isolated aortic truncal insufficiency, and then you have the mixed aortic and truncal disease. Okay, it seems like this partial heart transplantation is a safe procedure in the sense that the mortality was low, and there was actually 3 cases out of the 35 patients who actually died, but none of these deaths were actually related to the heart valve transplantation. In terms of reoperation, 2 pulmonary heart valve living heart valve, I would say, required a stent, right, because of some regurgitation or, more importantly, some stenosis. 2 aortic living aortic valve were complicated with a pseudoaneurysm formation and underwent a repair of the pseudoaneurysm. And then there were 2 additional patients who required, replacement or an explantation of this valve, but for reasons not related to the actual transplanted valve, right? One was related to the fact that, the hood that was used to complete the RBOT reconstruction using a patch of cryopreserved homograft, not living homograft, but cryopreserved homograft, shrank with time, right? And so needed to be replaced. And then another patient had actually a compression of this pulmonary living valve by the sternum and required to be changed. Okay. So a total of 29 patients who did not require any reoperation or reintervention. overall, this valve function well, right? So roughly 90% of this valve with on this study, which has a median follow-up of 8 months and a maximum follow-up of 3.8 years, 90% of this pulmonary valve, have no or less than mild to moderate pulmonary stenosis or pulmonary insufficiency. In terms of aortic stenosis, roughly 80% have less than mild to moderate aortic stenosis and 90% of aortic insufficiency. So you can see here the cumulative incidence of the primary outcome, which is defined here by more than moderate or more than moderate valve stenosis or insufficiency. So you can see that the cumulative incidence of this primary outcome is around something like 12 to 15%, right, at 12 to 15 months after the operation. There was no difference between the aortic and the pulmonary transplanted valve. This valve definitely grow, right? And we can actually say that, certainly, right? Aortic, you can see here the diameter of the aortic annulus and the percentage of change in the BSA, right? And there is a linear correlation, and same thing here for the pulmonary valve. As I was mentioning earlier, right, as we showed, in the first patient that we published, there is definitely some immunogenicity and immune response to this valve. So in this series of 35 patients and 42 valves, 70% of these patients develop a class 1 DSA and 75% develop a class 2 DSA. And around 60% of them developed high titers of the DSA. In this series with a small number of patients, it didn't seem like this DSA or this immune response was actually associated with, was associated with, moderate stenosis or regurgitation, right? Although, the class 1 seems to be a little bit higher in the patients who actually had this moderate stenosis or regurgitation, but there was no statistical significance. So what do we know so far? What we know so far is that it seems like heart valve transplantation is feasible, that the short-term outcomes, I insist on the fact that we are talking about short-term outcomes, are promising, and with largely preserved valve function. This short follow-up, median follow-up of 8 months, maximum follow-up of around 4 years. And that this is feasible in a heterogeneous population of patients with congenital heart defects. Okay, these valves demonstrate an adaptive growth, and they do elicit an immune response. But we don't really, I think we can say that we don't really understand, whether or not this immune response has a clinical significance or not. So that was, up to April 2025. Since then, a few other centers have actually done partial heart transplantation or living valve transplantation in the US, right? So, So Niklaus has been doing some Arkansas, Children's National, Cincinnati, WashU, St. Louis, Vanderbilt, Loma Linda, and University of Minnesota. So a total for what we are aware, but maybe there are more, right? Which would be the whole point of this registry, right? So far, 13 centers in the US, probably around 50 patients benefited from this technique, for an estimated total of valves implanted around 65 to 70. So there are there is a lot that we don't know, obviously, right? I was talking about the short-term outcomes, right? But the mid-term and long-term function of the valve and growth of the valve, we don't know yet, whether or not, these valves are functioning well long-term. What the impact of the patient selection, what the impact of the origin of the allograft, the impact of the processing also of this fresh valve, the impact of the immunosuppression protocol and what should be the right and the correct immunosuppression protocol. Also, you could think about the safety of the immunosuppression protocol versus the reoperation for cryopreserved of home graft, and also the quality of life and the healthcare. We can think about a lot of questions, a lot of answers that would be needed to really guide our patients who are more and more who are coming to us, for this type of technique, and we don't have necessarily all the answers that we should. So we came up with this idea, at a multidisciplinary group and collaborative group about doing this registry, right, for a partial heart transplantation. And thanks to the leadership and the support from the CHSS, we are close to start this registry. So that's a prospective, multi-institutional, longitudinal PHT registry to know more about this new technique. So as I said, prospective multicentric enrollment with a retrospective arm, because the idea would be to include all the patients that have been already implanted. We had broad eligibility criteria, right? We want to be welcoming and to include basically all the centers who have been performing at least one valve transplantation. And we want to include all the valves, right? Not only aortic pulmonary, but also the AV valves. And we designed this database so that it's pretty flexible, because there is a lot of things that we still don't know, so that we can little by little, when we know and when we learn new things, we can actually, change, right, and add new variables to this database and to this registry. We estimate that the annual enrollment will be around 40 patients per year with a conservative growth rate of 25%. My gut feeling that it will be much more than that in the coming years. And we plan to observe this patient and to follow this patient, lifelong. So because we are planning to do that lifelong for this patient, right, there are definitely some costs. So initially the registry was supported by the Brett Boyer Foundation, thanks to the support, thanks to the work from the Duke team, right, for 200K. And recently, we were able to get a sustained funding from Nicholas Children's Hospital of total of 750K for 10 years, right, 75K per year, to be able to hire a full-time research specialist just for this registry. So we started doing that by setting up basically a registry steering committee. Doug and I are the co-chair of the steering committee. We have registry experts, from Cedric, mainly from the CHSS. Dr. Blackstone from Cleveland Clinic also is helping. Linda Lambert is a data coordinator. And then we also included surgeons, cardiologists, and immunologists pretty early in the process. So what kind of data are we including? So first of all, the data about the recipient, right? To see, the potential impact of the heterogeneity of the patient and the functional outcomes. So the diagnosis of the congenital heart disease, the age, the weight, surgical history, genetic syndrome, comorbidities, the indication, and the valvular function to begin with. Then you have some data about the donor, the valve diameter of the donor, the indication for why the heart was rejected, or the indication for the orthotopic heart transplant in the case of a domino valve transplantation. Split versus non-split transplant, total ischemic time, the storage conditions, the preoperative immunosensitization of the recipient, some data about the immunosuppressive regimen. And I will show you a little bit later the CRF, so there is no need to go through that now in detail. Some data about the growth of the valve, right? So the donor of the transported valve, the BSA of the patient, and also, the length of the leaflet and the height of the coaptation. The function of the valve, right? How this valve is functioning in terms of stenosis and regurgitation and mobility of the leaflet, and how the leaflet look like an echocardiography. Patient outcome and valve outcome, right? Reintervention, readmission, mortality. And then we haven't included, the data about the cost, but in the future, we probably want to do that. How does the follow-up look like? So we agreed that, this patient the time point, right, in the registry are the following: pre-op, intra-op discharge, then every 3 months for the first year, then every 4 months second year, then every 6 months for the third year, and then every year. Okay, and the clinical variable and the echocardiographic variable are some of the variables that I just mentioned earlier. I will not go through that again. Okay, so we'll use the CHSS core imaging lab to limit the operator-dependent variability of, to read this echocardiography, right? So the idea would be to transfer, and then we can talk about that a little bit later in more detail about how this transfer of the echo and images will be done to the core imaging lab. In terms of immunosurveillance, right? This immunosurveillance should be performed at the same time points as echocardiographic and clinical follow-up, right, with DSA, PRA, and for those who can or want, the cell-free DNA. This is not, something, obligatory. So let me stop sharing this document just for a few minutes, and then I will show you briefly the dictionary. Give me one sec.
David,
Yes.
at the risk of not typing my question in the box, which I'm sure I can figure out how to do eventually, do you intend to capture for those patients or those valves that are explanted any specific data, histology, and the like?
That's a great question, Jake. We did not include that in the registry, although obviously, that would be fantastic to have to include the specimens, right, in the registry. But yes, that's definitely something that we can do and would like to do. Mm-hmm.
Thank you.
Okay, I will not share the, wait, this is the data dictionary, right? So I guess that, do you see this dictionary? Yeah. So we will not go into the details of that, but basically, that's the dictionary that, you guys would have access to if you are interested in participating in this registry, right? To have the, definition of all the variables that we want to include. So that's the first thing. And then also, let me share the CRF. So that gives you, so that was, based on REDCap. As we will discuss in a few minutes, all this data will be included into the CHSS cloud system that Cedric Manillo set up. But this is a better, an easier way to show you, the type of data that you will enter. So the demographic of this patient, right? Date of birth, gestational age, birth, weight, sex, indication for valve transplant, diagnosis, genetic syndrome, extracardiac anomalies, prior interventions, the preoperative DSA and PRA and cell-free DNA testing if available. Then you have the preoperative echocardiogram, BSA, the valve anticipated to be replaced, and then for each valve, regular start regurgitations, this gradient, diameter, this score, the mobility of the leaflet. For the pulmonary valve, for the aortic valve, as I mentioned earlier, we also want to include, mitral and tricuspid. This is done, and then data about, LV and RV dysfunction, function and dilation. Then you have the operative data, right? Date of operation, institution, type of valve, preoperative risk factors, domino versus non-domino transplant, split or non-split transplant, the cause, the reason why the donor heart was not transplanted, ABU compatibility or not. Then the characteristic on the donor echocardiogram, so the diameter, the gradient, regurgitation of each valve. Then the intra-op data, the cold ischemic time, the storage temperature, the storage strategy, whether or not they were just static cold storage or in a shopper pack or others, bypass time, aortic time, then the post-op echo. I will not go again through that. That's the same type of data that we are using for the pre-op echo. Then the post-operative data, length of stay, usual stuff for ICU. I will not go into the detail. You can see some of them briefly here. Reoperation, reintervention. The immunosuppression protocol. So the preoperative immunosuppression, intra-op and discharge immunosuppression, dose and schedule. Immunosuppression-related complications during the first admission. HLA, PRA, and DNA data. Then you have the discharge echo, same variables as before. Clinical follow-up, alive or not, date of death, cause, readmission, date, reason, reoperation and reintervention. And then the follow-up echo, the follow-up echo, and then finally the immunosurveillance. So that was just to share very briefly, the CRF, which is actually already part of the CHSS cloud system. So let's go back to the slides. One more thing. Okay. So where do these data will be stored? I don't know if Cedric is not on this call, right? I don't believe so. Oh, sorry. So most of you are aware, right, of what Cedric Manillo basically built. Jack, do you want to explain that?
Yeah, so for those of you that aren't aware of him, Cedric is a data wizard who works in the CRQ arm that is in Toronto. And over the past year and a half or 2 years, he and his staff have constructed a cloud-based storage system. It's not used to be called the Azure environment. It's called something even sexier now, but what this allows for is remote access for people granted appropriate security privileges, and each of these zones is a higher level of security. But the data entry and data storage will all be rather than the somewhat old-fashioned way of either emailing or hard snail mailing papers to a place that just sticks it into a database that is in Toronto. This cloud-based facility makes this much more accessible and modernized. And so this is a schema of the design of the database, but in simplest form, the data will be stored in the cloud. Access to the data for investigators, for participants in the registry and so forth will be on the basis of security access, which is granted based on essentially need and meeting certain criteria for participation. And this overcomes a lot of the difficulties that we have had in the past with other cohort storage. So this is a great leap forward for the CHSS.
Great. Thank you, Jake. Now, about the regulatory aspect of all of this. So, Linda, so do you want to talk about that?
Yeah, sure. Hi, I'm Linda Lambert. I'm a nurse practitioner and the administrative director of research here in Salt Lake City at the Children's Hospital, and have been involved with the CHSS, I guess, initially for a number of years. So I'm just going to talk a little bit about regulatory. The PHT cohort is implemented within this CHSS CHQ registry protocol version of April 25th, 2025. We refer to that as the single IRB. It's not a single IRB process in that each institution has to have their own IRB and their own data use agreement. However, it's the same protocol throughout all centers. The sites may have to reach out to their IRB and inform them that they're going to be enrolling a new cohort. Not all IRBs will require that, so it really will be site dependent. So if you are uncertain about your institution, then I would suggest you reach out to the CRQ to clarify it so that we can make sure that everybody is on the same page. We'll be enrolling both retrospective and prospective enrollment in the PHT cases. We won't include annual surveys that will go out. Typically, these have gone out from the CRQ or the data center. Consent requirements will be determined by your local IRB. The CRQ will accept a waiver of consent if it's permitted locally. Sites will also, who are also already active in the CHSS CHC registry, like I said, may have to inform their IRB of enrollment in this new cohort. But because it was included, I would say that for most sites that won't be necessary. The data will be able to be entered either centrally by the CRQ or locally at your site according to the site's preference. Next slide. So here you can see on the slide, we rolled out the registry to 52, well, there's 52 sites within the CHSS that had involvement in CHSS studies in the past. We had pre-submission meetings with 40 of those sites. Of those, 17 sites have submitted their IRB and 14 have IRB approval. Along with that is the data use agreement or the data transfer agreement. Given that now we are including not only Sick Kids but Cleveland Clinic, it's necessary for this to be re-executed. So there are 26 sites that have received the data transfer agreement that are pending and only one site that has it fully executed. So the next steps are the registry onboarding, meeting with the data center one-on-one. I think most sites have already done that. That are interested in the PHT for sure. If there are sites that are interested and have not done that, then we're certainly welcome, or we're certainly willing to meet with them, and they're welcome to reach out to the CRQ. In order to be able to start involvement in this registry, you will have to have local IRB approval, as I mentioned previously. You will have to have the data use agreement in place with Cleveland and Sick Kids. And then we are doing some site training so sites understand exactly and everybody's on the same page to start with. So we would want site training completed before we actually give you the green light to go. And then once that's completed, your site is able to do the data entry into the registry, or as was previously mentioned, the CRQ can do that. They can send data. Currently, there are 14 sites that have IRB approval. You can see those listed here. These are the sites that we know of to date that have already been able to get through their IRBs. Next slide, the sites that are, of those sites that have IRB approval, there are 4 sites that have IRB approval, 4 sites that are currently doing the PHT. There is only 1 site that is currently activated in terms of having not only the IRB but also the data transfer agreement in place, and that's Cincinnati Children's. I think that's it for me. Thank you.
Great. Thank you very much, Linda. Okay. Another important point also for us was to have the buy-in, of all these institutions who are interested in participating in this registry. Right, we would like to actually do some regular reports of the collected data because we know that it's a new technique. So we want to update, the participating centers about, the data that we collect with a prompt sharing of important findings, right, for the patients. We will plan also to give some updates about this registry at national meetings, the CHSS obviously, but also the ATS and the STS, and site reports can be provided to the participating centers on their own data. The whole point of doing that is obviously to have the opportunity to get the first longitudinal and prospective data on partial heart transplant. To help doing future clinical trials down the road, and more importantly to help with increasing the clinical adoption of this technique. And down the road, this registry can actually be used, I think, also to evaluate other stuff related to the evaluation of living and fresh homograft, such as different types of novel valve storage technologies or different kind of allocation systems. So this registry can actually, I think, the basis to do other very important endeavors. So what are the ongoing steps? Right, so we had identified at the time of the last CHSS meeting that we wanted to do this webinar, right, to inform our community and to welcome any group who are interested in participating. The second step would be to hire this dedicated research specialist that I mentioned, who will be working at the CHSS CRQ Cleveland Clinic site, using this 10-year-long dedicated funding from Nicholas Children's Hospital. We also need to validate the strategy to upload echocardiography to the CHSS imaging core lab for central imaging analysis. And then we'll be able to actually start the transfer of the data in the cloud system that Jake mentioned. And we'll be ready by July 1st. And on the regulatory aspect of things, as Lida just mentioned, right, we still, keep working in terms of IRB approval and fully executed data use agreement, right, for those who are interested in participating. So we stop there in terms of slides, right? Jake, Annie, Doug, Linda, and myself are happy to take any questions.
There's a comment from Awais Ashfaq from Cincinnati, David, in the chat. I don't know if you guys can see that, but he says another thing to consider adding to intraoperative variables is plasmapheresis or plasma exchange, or how much, as with other organ transplants, Awais describes having used this for valve transplant recipients that are incompatible or sensitized. Maybe Doug or David, what do you guys think about that?
I think that's a great idea, Wise. Thanks for adding it there. I think all these boxes that we're trying to check as far as immune reactions and concerns, we should collect as much as we can, and so there are things being done at various centers that the most aggressive obviously is to treat these just like an organ transplant, right? And the least aggressive is to do no immunosuppression afterwards. And so we have a multi-prong approach for how we approach these, but every center does it differently. And we've heard that with post-operative immunosuppression as well. So I think we have to make a registry that collects all the appropriate data for each piece along the way. And so that certainly is a great box to check for the intraoperative variables.
Yeah, I agree. And I think that, this registry is really something like, it's multidisciplinary work, right? We would be very happy to have more insight from other groups, who want to participate and to participate to actually how it is built. So, iOS, that's a great suggestion.
Linda, you've been doing studies for a long time to understate the circumstances and are very aware of the regulatory hurdles, or not regulatory steps, I think is a better word to say, or a better way to phrase it. It sounded as though you said that one institution has gotten through everything, which by coincidence is Awais's institution in Cincinnati. I wonder if you'd be willing to be a resource, and Awais actually for that matter, for surgeons and interested participants, because obviously the success or failure of this registry depends on maximum participation, and I think the wisdom of the leadership to include retrospective entry is huge. But what would you be able to help other people who want to walk?
Yeah, certainly. I'd be happy to be a resource to not only the surgeons but the coordinators as needed. I think anytime you add a new project or a new study, something that's as unique as the PHT will certainly be. I feel like there will be questions, and I'm happy to address any of those questions and to support them in any way I can.
That's great. Thank you. And, David or Doug, can you guys talk a little bit about what you envision as, I know you went through it on the slides, but maybe in a little more flesh out what you envision the output of the registry. Certainly there will be papers that will be presented and people will be interested in that. But then, for example, other registries that we're all familiar with, like the ISHLT registry, issues reports on a regular schedule, sort of updating each year at the annual meeting, a set of slides for this is what happened in the last year. Is that the kind of schedule you guys are looking at? And obviously, once you get the data person hired that the funds are going to support, they can do more of that. But anyway, could you guys talk a little bit about output?
Yeah, absolutely, Jake. We want to this registry to be as productive as possible and more importantly, as helpful as possible for our community and for the patients, right? This is what we want at the end of the day, to be able to answer the questions that the patients, are asking us. First of all, if we notice some significant trends, either positive or negative, we'll have a lot of show to communicate these important findings, quickly, right? We not wait for actual publication, right, to make our community aware if these findings have a clinical impact on our patients. So that's the first point that I would like to mention. The second one is what you said, right? We'll actually do some reports, some regular report, probably to start with, twice a year, right? And we'll send a report to the groups who are actually participating to this registry with some, data. It can be descriptive data at the beginning, and then some statistical analysis when we have some analysis. The other thing is also doing some updates, right, at our scientific societies meetings, right? Obviously the CHSS, but also the AATS and the STS. As part of the CHSS, meetings during these conferences. So these are the main things, In terms of publications, obviously, we definitely want to publish, some of these findings. Anything else, Doug, that I...
No, that's great. That's exactly right. I think from an output of what you would imagine a database, that's exactly right. I mean, from just the vague answers of what we want to see out of it, in the short term, it's what's the adoption like for partial heart, right? What centers are doing it? What indications are they doing it for? And then midterm, is it working or not? Is everybody seeing these valves growing? Is it under certain conditions that they do or don't work better? Does it work better in the left sided position, the right sided position? What type of valves, what immunosuppression regimens? And then the longer term, we of course want to eventually find out how these compare to cryopreserved homografts, right? And other options that we have. And so I think there's a lot of components just based on duration that we're going to see different questions answered along the way. And the only way to do that in a way that's transferable across the nation is to get all these institutions together and try to capture as much data we can. And so that's our goal.
Absolutely.
There's a question from Bill in the chat about
one last thing, Jack, it's about also, using this registry as the foundational step to do actually clinical trials down the road, right? I think that, we should insist on that, right? That our aim down the road will really be to do, clinical trials, and going through this first step as a registry is something, important.
That's a great point, David.
And this data can also be used, to inform other types of research going on in the field of living valve, right? Such as allocation systems, such as new technologies to preserve this valve, and so on and so forth. So that's really a platform for much more, I would say.
Let me ask a question. I know there's a. Sorry, Doug. Go ahead, Doug.
I was just going to say, I mean, it seems to be expanding at a very rapid rate, which is, I think, the exciting part about trying to capture that in a registry because it allows us to show what other centers are doing, right? So, I mean, we hear about other centers using this for patch tissue that's going to grow over time. They use the leaflets from these valves to do Ozaki type procedures. There's been mitral implants. So there's a lot of variety that goes on that extends beyond just the standard simular route that we're used to.
Only thing I would say, Doug, I'm interested in your and David's opinion as to now. There are still a lot of heterogeneity of the immunosuppression as well as the timing of implantation and the storage mechanisms and so on. When would you think that it is? Obviously, we're going to collect this data, and you're hoping to see the difference in the outcome, one versus the other. But when there are a lot of heterogeneity and these variables, how are you going to discern the outcome which is better in one way or the other? And would it be reasonable to set a time that you say we will review this and then in 3 years and then choose a set of protocol recommendation, I would say, for different centers. What do you think this would be? Do you agree that the heterogeneity is going to probably impact the essence of this project? Let's say you're supposed to store the valve for 12 hours or 24 hours or 2 days.
Yeah, that's a interesting question, Hani. I think that the heterogeneity actually can be a weakness, but it can also actually be a force in the sense that this is something that, that's a new field that we are really exploring, right? So by limiting, so first of all, we do not aim at limiting, or guiding the clinical practice of other centers because there is not much data, but there are some clinical data or some, animal and preclinical data and bench data giving some ideas of the leaflet and the viability of this valvular endothelial cells and the valvular interstitial cells, both in vitro and in vivo. Still, we don't have enough data, right, to make recommendation or to limit, people. So, yes, of course, as always, right, heterogeneity will be something that we'll have to deal with from a statistical standpoint to try to answer questions. But on the other hand, it's also a kind of a force in the sense that maybe it will help us and our community to understand more about all of this, including the storage, all what you said, right? The duration of the in vitro storage, the processing of this valve, and so on and so forth.
Yeah, I completely agree, David. I think that the initial guidance is always science, and for us, that's animal studies, that we've published in terms of timing and what we think will work with these. But obviously, that doesn't always apply to clinical practice, right? So we have we develop our initial protocols based on that, but then let's say we find so we did our 39th one at Duke last week, but I bet you there's been 70 of these done in the country or 80. And so once we get closer to that 100 number, or we have 4 or 5 institutions all together, which should be by the end of the year with this registry, then we can start refining that more, right? And maybe we find that the occult ischemic time isn't 5 days, maybe it's 2 days. Maybe they do better if it's within 24 hours. I mean, those are all the exciting questions that we can capture from this data set once we have more and more people and patients to examine.
Which goes back actually to the importance of updating our community when we start identifying trends, right? I think.
There's a question from Bill DeCampley, which is a practical one having to do with how the registry is going to handle echo information. You showed us a data, a clinical report form, David, that had a bunch of echo variables. Another way to handle that is to simply send in the raw echo and have the core lab read it so that that's standardized. And that certainly the data structure that's been created by Cedric is capable of handling echoes in standard echo format, and then having a core lab read it. So how are you guys intending to approach that? Will you just simply go off quote echo report forms that are scripted so that the echocardiographer in Durham and the echocardiographer in Miami and the echocardiographer in Cleveland are, please fill this form out, or the coordinator transmits it, or are you intending to try to get the actual raw echo and have a core lab read it, or some combination?
So we had a long discussion about that, in the group, and so we thought that, as Bill just said, right? I mean, the echo will be absolutely critical, right? The echo data will be absolutely critical to this registry because it's more like you don't want to know the outcomes of the patient, but more like the outcomes of the valve, right? So obviously the echo will be absolutely critical. So we decided to send all the echoes, basically the raw echoes, to the echo to the core lab, right? To really make sure that we have homogeneous reading, right, and assessment of these valves. So this is the decision we made. Obviously, that's more resources, right? But that's the reason why we actually wanted to have a dedicated and sustained funding for this type of registry, because that will be a significant amount of work and resources.
That's great. Thank you.
Another question is from Kamal Omagadam. Have we had an opportunity to obtain tissue sample from these implants after implantation in any redo operation? Have we explanted any? It's similar to the question that Jake was asking. Are you going to actually get any pathology? Yeah.
Yeah, we've explanted 3 of these, and we're trying to put a paper together on it that shows the histologic findings. So hopefully that'll come out soon. I mean, it can be tough on these. We have some good videos to show clinically when you take it out that they're still soft and they seem like they're alive, as opposed to calcified hard homografts that have obviously failed from calcific stenosis. These are different. They look good, they're soft, the leaflets still move, but as far as the histologic data of which cells were replacing what, that we've had to go a little deeper with that as far as like electron microscopy and all, because just having cells that are infiltrates that are of the recipient doesn't necessarily mean that it's reendothelializing, right? It could mean that it's an immune infiltrate that's rejecting the. So we're actually having to go a few layers deeper as far as our cellular analysis of the explants, and so we're trying to get that data together.
David, have any been explanted in the Columbia experience?
No, we haven't.
How do you match the size, David and Doug? So do you go by age, by weight, or by echo sizing, or what?
Echo sizing.
Echo sizing.
Yeah, echo diameter, right? I mean, basically the BSA or the age or the weight of the patient don't really matter, at least to me. I don't know, Doug, for you, but it doesn't matter, right? Obviously, neonate with a dilated truncus annulus, right? You put what you have to put, right? So we just go by diameter. For the mitral valve, that's a different story. There are different thinkings about that. You can go by diameter, by length of the leaflet, by height of the pap muscle and the chordae, and so on and so forth. But overall, it's by echo measurement rather than weight, age, or BSA.
Yeah, that's how we do it. I mean, so for the truncus population, they're always going to have a big truncal root, so you can fit a larger valve in. But for critical AS, you're going to want it Z of probably 0 to +2 is the range that we generally try to fit in. So for neonates, these are 10, 11, 12 millimeter valves. For bigger patients, that are getting let's say a TET PA, then they're probably getting a 13, 14, 15 millimeter valve, something in that range. I mean, you have to remember that you just can't be too picky, right? Because if you're looking for a 13 millimeter valve that's blood type matched, there's going to be one across a 3-week period in the country. And so it's just hard to get exactly what you want. It depends on the acuity of the patient. Obviously a truncus with severe regurg, you have to kind of take whatever infant valve you can find a lot of times. But we found that, in general, we try to stay with the Z of 0 to a Z of +2.5 for, most positions.
I think that's important. And you're right. You can't pick, and you want to make sure. Although from the Ross experience, if you put it in a larger environment, you're setting it up for failure because it's a larger environment, annulus-wise or virtual basal ring, like AI. So maybe that, I don't know if it's going to apply the same. It's supposed to be live tissue, like the autograft. So more to come on this one. A lot of, and I'm glad actually we do have heterogeneity, so we can find out those who started off with a larger annulus do same or do worse, as opposed to exact match. So
Yeah,
Yes, you
that's
guys.
another important consideration is like the critical AS patients. If you do a big, conal root enlargement, let's say, then maybe half your graft is touching patch and it's not touching native myocardium. So it may not engraft and grow in the same way that you predict, which is something that
exactly.
same with using an aortic over in the pulmonary position. We have seen one of those fail, and I think it's just because the pressures are different, right? So maybe the growth that the valve is used to seeing doesn't occur as well. All things to be determined.
One of the practical things that's occurring to me as you guys are answering these questions, ad hoc as they come in, and I'm sure that the other people who are probably eating supper and not asking questions have questions. As this technology or this concept begins to proliferate, having a kind of a user group that met at some intervals that are somewhat frequent and predictable, where the two of you guys. Maybe Joe, a couple of other people that have experience could field questions from interested surgeons. I know both of you to be very accessible to someone who has a question about something, and I'm sure you will remain that way. But if there were a kind of an interested group of people that met, there is some precedent for that within CHSS having to do with the anomalous aortic origin of coronaries that Anusha has been running for some years now. And you certainly don't answer it now, but one of the things you might think about to facilitate the launch of the registry and just this community is to think about maybe, the first Monday of the month at 6 o'clock, there's a Zoom that's open, and the CHS would certainly be happy to sponsor that or facilitate the construction of that. And once you've got your target person identified to support the registry, David, that person could maybe act as a clearinghouse. But just a way to exchange information. Obviously with modern technology, we've got a lot of different ways that we didn't have 10, 15 years ago, but something to think about where people can exchange information in the way that we've done here.
That's a great point. The other
I would
important
suggest, I would suggest also, Jake, you remember if the CRQ report out on the annual meeting, since we're starting in July 1st and the annual meeting is 3 months later or so, maybe we should dedicate that a few minutes, 5, 10 minutes,
100%.
whatever, just to update everybody where we are with it.
Yep.
So July 1st to June 30th or so. And we just update every time. So an ongoing thing. So people, and I'm glad Bill DeCampley and Jeff Jacobs are on and listening, so we can continue to do this as we go along.
Linda, do you have a question?
Yeah, no, actually, just a comment to Dr. Najam's point. I think one of the other things is to make sure that you keep the study coordinators in the loop. Sometimes the information that you guys want isn't always passed down in a timely fashion. And we, as a coordinator group, have quarterly meetings as well as we have newsletters. So we can certainly disperse information in those two mechanisms as well. And I would suggest that perhaps maybe once we get up and rolling that one of you participate in the nursing or the coordinator meeting and just present the study, give it a high level overview. You don't have to go through all the information, but I think it would be really important for them to understand the study and to understand the points, because I've heard a lot of things of how important certain variables are. And one of the things that is sometimes difficult is like getting echo images, getting more granular information. And if that is specifically very important for the study, I think that if we could stress that point with the coordinators right from the get-go, how important that data is, I think we'll have more success with our data and less missing data.
This is crucial. The people that make this sort of thing work are Linda and there's no one like Linda, but people that do what Linda does at other institutions, and her point is outstanding. That's going to be the lifeblood of this registry is the coordinators at the centers.
And one other point, if our timeline for our quarterly meetings doesn't match up with the launch, we are certainly able to have an additional meeting or an additional session with the coordinators to make sure that everybody's moving in the same direction.
We have another question from Bill DeCampley. How are the units integrating donor management into their overall heart donor management process? Are recipients stratified by urgency, and how is the list regionalized? So a bigger picture on other organization being involved in organ distribution, and how has it been? Can you elaborate a little more, David and Doug, how the organs have been procured? Have they been all from the same institution? Have they been transferred to another institution? How has this been going so far?
I can share the experience from this multicentric study. So in the multicentric study that I told about earlier, 61% of the valve implanted were domino valves. Okay, coming from the same institution. So that gives you an idea of, how the domino concept using valve from explanted hearts from the same institution has been playing a role. In the rest of it, right, in the 40%, then these valves have been coming from two main sources. One source is, valve coming from the donors, brain dead donors, right, and through the OPOs. So usually we use to contact OPOs to let them know that we have a potential recipient, and then to let us know whether or not they have a valve. And recently there have been, a company called Surge Ingenuity, and I will let Doug talk more about it, right? Who has been able to provide some centers with fresh and living valves, right? So these are probably the three ways to get living valves as of today.
Yeah, that's exactly right, David. I mean, we went through all three versions of that at Duke, which is what led to eventually Joe starting, kind of trying to make a more widespread nationwide valve procurement organization available. I'm not like attached to that in any way. So I have no conflict of interest with Surge Ingenuity. I receive nothing from them other than my partner Joe Turek spends some effort on it. So I probably work more because of that, but. Ultimately, that company is designed to try to help people get that one 13 millimeter valve that exists across the country that you need. And so, you can look into the company yourself and decide if it's something that interests you or not. But the other two ways, finding a valve yourself in your own hospital is one way, and then sending out that letter, to all the OPOs across the country to see if somebody will tell you when they have one is the other way, like David mentioned. And so hopefully, there is a better way, obviously. We need a wait list. We need all that organized in a way that we can get valves from other places across the country for the size that you need. And that's what led to kind of the development, I think, of the company. But I'm not directly related to it in any way whatsoever. Ultimately, though, I mean, if there's a way that we can get valves to people that need them at the right time frame, then I think everyone benefits from that, right? And so that's the purpose, at least, behind it.
And the output of the registry, I think, will be very helpful to help our community to organize ourselves, right? And to establish something together to really answer this huge need, right? About an allocation system of these living valves. If, results are good, and if our community keeps implanting living valves, I think that the data from the registry will be key to do that together.
We're above an hour. We have one question now, but I probably will take that last question. If there are any burning other questions, please type them quickly so we know. This is again from Kamal Forma Gadam. Did I understand that all at 15, or is it AI at 15 months follow-up is around 12%. Do we understand the process? Is this selection size related? Question mark. So it's about the AI. Is it 12%?
The freedom from AI was 91% at a median follow-up of 8 months and maximum follow-up of 3.8 years in these 42 valves implanted between April 2022 and April 2025.
Okay. I want to ask Dr. Jaquez, our president, if would like to comment and probably close the session, or if there's any comments by the panelists also, Doug or David or Linda.
I think this is very exciting. I think that, for our community, it's a really, really exciting and very important initiative. It also shows how much, a pediatric cardiac surgeon in the US can collaborate to really advance the field, right? It really also shows, how some groups can also collaborate with the CHSS and how the CHSS can be our society that can support us, pediatric cardiac surgeon, to launch this type of work and registries or studies. I think that's a good example of what the CHSS can do.
Yeah, I agree. This is, a hallmark of a national society that's really functional, right? Is we can all get together, talk about our experiences, decide what's working well, what isn't working well, exchange information. So, this is a fantastic way to use the society, to move the care of these patients forward. But it definitely is reliant on everyone, being involved and entering their patients whenever they do this. And so I really appreciate people logging on to the webinar and then also, getting involved as far as being able to enter patients into the registry, because we want to try to capture all of them if we can, and then we'll look back and see what's happening over time.
Yeah, I'd just like to thank Hani, David, and Doug for their leadership in this. This is, as all three have just said, this is a spectacular opportunity here. And the people that were on the call and the many others, this will rise and fall, succeed or fail, depending on participation of the group. And so we all have an opportunity to help propel this forward. And don't be shy in asking for help or asking to participate in making suggestions. We heard several good ones tonight. And for people that haven't yet dipped their toe in, and I would include myself in that, I'm going to rely very heavily on advice from David, from Doug, from Aways, who started a program in Cincinnati, Conrad, others who have started programs. And I encourage everybody to dive into this thing. This is one of the most exciting things, if not the most exciting thing I've seen come on the horizon during my professional career. So thank you to all for participating this evening and going forward.
That's great, Jake. With these words, we'll close this, and please, we'll look forward also for subsequent webinars as we go along the year. So more to come from this team. Thanks, everyone.
Thanks, guys.
Thank you all. Have pleasant evenings.
Thank you.